Welcome to Value-Based Care Insights, brought to you by Lumina Health Partners, a national healthcare consulting firm focused on improving the strategic, financial, and operational performance of provider organizations. On this program, we will explore trends and share valuable insights on how health systems and medical groups can optimize their performance to meet the demands of this increasingly complex healthcare environment and shift to transform the delivery of care. Value-Based Care Insights is hosted by Daniel Marino, Managing Partner of Lumina Health Partners. Daniel has been in the industry for over 3 decades and specializes in shaping strategic initiatives for organizations in areas such as population health, clinical integration, physician alignment, information technology, and data analytics. For additional insights, visit luminahp.com and sign up for our newsletter. Dan, over to you.
Welcome to Value-Based Care Insights. I am your host, Daniel Marino. On our program, we've had a number of guests who've shared with us their insights on academic medicine. And as we've discussed time and time again, the world of academics, as we think about productivity and supporting the different priorities within the academic mission, it is definitely different than community-based care, mostly due to the goals and the objectives of a lot of the providers that are within academic medicine. I mean, many of the academic institutions, they have their clinical mission, they'll have their research mission, they'll have their academic mission. And many of them have worked through all 3 of those missions, which really provides a lot of competing priorities. But in the end of the day, what we are starting to see and have seen for the last number of years is there's continued pressure on the academics to provide the right level of financial performance, the right level of ability to expand, and really supporting or, let's say, connecting with their community-based provider partners. Well, I'm really excited today to have 2 wonderful guests who have an incredible amount of knowledge in this area. First is Dr. Joseph Bosco. Dr. Bosco is professor and vice chair of NYU Langone Health Orthopedics. In his role, he's led his department's transformation from a single specialty orthopedic hospital to a clinically integrated musculoskeletal delivery system. And then we also have Jeff Peters. Jeff, as a frequent guest on the program, he and I have worked together for many, many years, is a national expert in strategy, helping organizations anywhere from health systems to individual hospitals to medical groups, helping them with their financial improvements, strategic growth, and a lot of service line development as well. Dr. Bosco, Jeff, welcome to the program.
Thank you, Dan. Great to be here. Hi, Jeff.
Thank you. It's an honor, Dan. Thank you.
So Dr. Bosco, maybe we could start with you. As you think about some of the challenges that academic medicine has, particularly the financial challenges, and things are changing. We're not seeing the level of reimbursement that we used to. We're not seeing the funding that we used to. And there's continued pressure on the academics to change their model. What are you seeing as you talk to your peers around the country?
Well, I think we're all experiencing the same thing. Traditionally, as you mentioned, academic medicine had three goals: clinical care, education, and research. And that really hasn't changed as much. It's just that, frankly, in order to do your research mission and your education mission, you need to have a very clinically relevant and make money clinically, frankly. No margin, no mission. And traditionally, and that, even now, education and research doesn't reimburse enough to keep a hospital and medical school afloat, frankly. So it's the clinical mission that funds much of the research and the education, especially. So
right. I agree. I mean, there's that focus has really been over the last couple of years on more of on the clinical mission. Has it changed the perspective of how some of your colleagues in academics, their perspective on how they need to be productive? I mean, many of them have gone into academic medicine for the mission, right? To really be able to support maybe other areas. A lot of them see themselves as scientists as opposed to just providers. Are you seeing that change?
Yes, as really the pressure, financial pressure, is ratcheted up, and especially in orthopedics. Frankly, orthopedics is a little different because most orthopedic surgeons, like what we do a lot clinically, and also even now it gets reimbursed at a very high level. So when you hire a person that's going to be a half clinician, half scientist, right? And that's what they do. They are making a sacrifice with the income they make. And that's just the way it is. And so what we see happening invariably is they want to be half clinician, half scientist, and that usually it evolves into 3/4 clinician, 1/4 scientist. And it's not just greed or want to make a lot of money. Frankly, we see it's because they enjoy doing the clinical part. So again, we really have to make an effort to make sure that the clinical activities drive and pay for the educational activities. And frankly, with the amount of consolidation that's happened in the healthcare industry today, right? Huge hospital networks. We went from a single specialty orthopedic hospital in Manhattan to now a clinically integrated network with 4 community hospitals, 6 surgery centers, and increasing accessibility. So that's what you have to go where the patients are. And so your physicians, your academic physicians, have to be able to move out to where the patients are, and sort of, if you will, get away from the mothership a little bit. If you don't do that, you'll be surrounded by a bunch of very adept surgeons or physicians giving high quality clinical care. And guess what? Patients are going to drive past 4 or 5 of these doctors to see the academic doctor in the middle of the city, right? Or somewhere in Iowa where they have to drive 3 hours to get to Iowa City to see the doctor. They're not going to do that anymore.
Yeah, it's going to really, and it limits the growth, right? It limits the opportunities. So Jeff, I know you've worked with numerous academic institutions across the country, academic medical centers. This is really a paradigm shift within their strategy. And you wrote a great article that came out in HFMA, I don't know, 3 or 4 months ago, on how you've captured working with one academic medical center and how you were able to help support their growth within the community, very similar to what Dr. Bosco just described. How difficult is it to have the leaders kind of make that paradigm shift, dealing with either the pressures within our industry or maybe even the culture that exists within the academic institution?
Yeah, so let me put the context. I think what Dan is referencing is the work that I've done over 45 years with the University of Chicago Medicine, which is a major academic medical center historically based in Hyde Park. And through an affiliation with what was once a community hospital, we built a network of family care centers in markets that they had less than 1% market share, and put in freestanding emergency rooms, primary care practices, specialty practices, supporting ancillaries, surgery center, and treatment centers for cancer. And it's been very successful in growing their market share from 1% to 20% in the targeted areas. And it's been adding $100 million incrementally to the enterprise. But what we're seeing is in academic medical centers, the physicians are very focused on their department. And just like Dr. Bosco references, how do we make orthopedics more accessible? How do we push it out? Unfortunately, as academic medical centers have built these integrated delivery systems, there's leakage. There's primary cares who are there, but don't necessarily refer to the specialist. A lot of the reason why is you see a patient in the emergency room, you want to refer them to an orthopedic surgeon, and the orthopedic surgeon only has hours 1 day a week at the ambulatory care center. That patient wants to access that specialist right away because in the market, there's other orthopedic centers have instant access. So increasingly, what we're seeing academic medicals look at is a new model that is like the traditional multi-specialty physician group practice, where there's primary care, there's specialists, they have ancillaries, they have a surgery center, and they're not just linked on their productivity individually or their contribution to the department. There are incentives so that they take good care of the patient. And if they prevent leakage and keep the patient within their multi-specialty group that's based there and use the ancillaries and all of that, there's financial rewards. I
Yeah,
think
that are kind of tied into that help to kind of drive where they want to go and reward the physicians,
right.
I think, for that new model. So let me turn to you, Dr. Bosco, kind of building on what Jeff had mentioned, as you start to think about driving that care into the community or even setting up different types of structures. I've always said form follows function. You need to have the right incentives in place in order to drive the right level of behavior. What are you seeing on the types of compensation modeling or the types of incentives that help some of the academic providers, the academic physicians kind of think about delivering care differently?
Sure. So I think, basically, there's no reason why you can't see patients and perform as like a community-based surgeon and be available, or have people that you work be available. That does not necessarily have to impinge or impede your academic mission. You could be a researcher, you could teach, and still have availability to see patients, right? So what we try and align people's incentives, because we know that if we're not available, if we're not provide service right away to folks, they'll go somewhere else. They'll go to one of the residents that we've trained that does a great job, right? So we don't want to lose those patients. No, we can't rely on this academic arrogance, I call it, that's been built over 30 years, saying, well, they'll wait to see Professor Bosco 3 weeks. No, they won't. They'll go somewhere else and see a person that's probably just as qualified as me and do a good job. So in many ways, we're in competition on a clinical basis for these patients, and we have to be available and affable.
Yeah,
If you're just
can I-
tuning in, I'm Daniel Marino. You're listening to Value-Based Care Insights. I'm talking with Dr. Joseph Bosco and Jeff Peters, discussing the changes in academic medicine and some of the pressures and challenges that are associated with delivering care. Sorry, Jeff, you were going to make a comment?
Yeah, thank you, Dan. I agree with Dr. Bosco that you've got to be accessible. You've got to you've got to take care of that patient, and you've got to take care of that patient where they live. That's still an evolving concept, Joe, I think, in academics, because there are the majority of academic physicians want the patient to come to them, to come to the Mecca. And, for really rare problems, it makes sense. But for the majority of problems that an academic organization is taking care of, it can be taken care of just as well and more conveniently in a community setting. And I think organizations that evolve, like Dr. Bosco, who has talked about, and I know his big message is, how do we improve our accessibility? Those are the ones that are really going to survive and thrive because they're responding to the needs of their patients.
Yeah. And you have to think about it. That's what I was kind of saying. It's that paradigm shift, right? You have to think about delivering that care differently, which I think in the academic setting, culturally, that could be really tough to overcome. You're used to doing it the same way within academic medicine, and really that has to change. And so as one example, we've seen across the country over the last number of years, certain specialties that are, these community-based physicians will partner with hospitals, with health systems to form these joint ventures either around surgery centers or some type of specialty hospitals or what have you. And it's a way to really align those incentives and to really be able to take it out to the community. What are you seeing, or Dr. Bosco, how are you seeing that playing out in the academic world? Are you seeing some of the academic leaders including that within their strategy, where you're forming some of those joint ventures with either maybe the departments, if they will, if they can, or certainly with the community partners?
Well, so I think we have to take it back a step. In order to be relevant clinically, you have to grow. As an academic medical centers, anyone, there's
Great point.
consolidation. Again, you have to grow your
grow.
clinical basis, right? Now, traditionally, academics, you have residents. So you have residents provide care. Well, resident work hours are decreasing, and it's very difficult to get additional residents. So you have a finite amount of resident work hours, right? And which is sort of decreasing, right?
Mm-hmm.
Then you're increasing your clinical volume. So then a higher percentage of your clinical care is going to be provided by non-resident physicians. So when we hire, we bring a group in, they may not have any contact with our residents, with our teaching. They work only with PAs. Some of our full-time academic faculty work with PAs in the office or in the OR. It used to be you had a resident in your office, and then when you went to the OR, that resident went with you. Well, that worked, 30, 40 years ago. It doesn't work.
Yeah, it doesn't work now.
So, you have to get away from that resident thing. The other thing is I just wanted to, we talk about, increasing accessibility for financial reasons. We're forgetting the other thing is that when you're at the Mecca, right, and you ask patients to access you're increasing socioeconomic disparities. We've done a lot of work on this. Yeah. If you're poor and you don't have a car, and you live far away, you're gonna have a hard time driving, 2 hours to see someone. In New York, we published an article where the driving distance didn't make any difference. But if you live in Queens, you want to come to Manhattan, it may be 3 miles away, but you don't have a car. You can't take public transportation.
Yeah, that's a great point. Great point.
Your children who maybe work at an hourly wage at a McDonald's or something like that can't afford to take off time because they don't have permanent, time off to take their parents to the hospital. So they're hourly wage people. They're going to lose money. So when you do the whole thing where you have to drive to the Mecca, you're increasing socioeconomic disparities. So you get out in the communities and you see.
And I love that. And I think, that makes so much sense. And I do a lot of research and I work with a lot of organizations on improving addressing some of the socioeconomic disparities. Do you think a lot of the academics take that into consideration with their strategies?
Well, listen, a couple of years ago, I looked at the Bank of America. They had a 200-page state of the art of medicine, right? And they said, well, you have to look at, high income zip codes and put your satellites in there, right?
Sure. Yeah. Right.
But what we've done at NYU, we've gone to the poorest neighborhoods. And what we did was we elevated the quality of care that the lower socioeconomic groups get. A lot of dual eligibles. That's been part of our mission. So when we look at our U.S. News and World Report rankings, we use one system's rankings, not just our hospitals, but these safety net inner city hospitals that we've taken over as well. And we're proud of that fact. Now, again, no margin, no mission. So, we still keep our eye on the bottom line, but that doesn't prevent you from going out and putting satellites in lower socioeconomic areas so you can take good care of folks, because that's what we're supposed to do.
Yeah, sure. Well, I know, Jeff, this has been a big area of focus for you as well. And you've incorporated this into a lot of the work that you've done with academic institutions.
Yeah, I think Joe sort of represents how academic medicine needs to think about providing care. They've pushed their services out into the community and they've provided access. So you have an ambulatory facility with an ER and somebody has a broken leg, they don't want the ER to stabilize it and then go see the orthopedic surgeon at the Mecca, and it's going to take you 2 weeks to get an appointment and you're going to have to drive an hour. They want the ability to walk down the hall from the ER that same day at the very same hour and have somebody who can take care of that broken leg or evaluate them to see if they need surgery. And the successful organizations are going to improve this access. It's the same thing when a primary care sees Mrs.
Sure.
Williams, who's a 95-year-old, and says, you know, we've been dealing with this pain in your hip long enough. I think you need to go see somebody to see if you need to have a hip replacement. We want to be able to go into our Epic system and say, Mrs. Williams, when do you want to see the joint specialist who's in this building 5 days a week and prevent that leakage? So
Right. Get them into that domestic network. I think that's really the key, but you have to, the only way that that's going to happen is you need to make sure you have the access models and the community-based facilities that would support it. So let me kind of address this or refocus our conversation. If any of our listeners right now, and there's a number of them that are within the academic setting, if they're thinking about changing their strategic focus, or some of them are really thinking about advancing their strategies right now to obviously enhance their financial performance, increase access, all of those things. Let's start with you, Jeff. Anywhere that they would start, or what would you recommend a starting point be?
I think what they need to do is they need to really have a discussion as to sort of what is the goal? How can they take better care of the community that they want to serve, and to look at that community in a broad geographical area, and then evaluate at the present time, are their services convenient to the populations they want to see? Is there immediate access to both primary care and specialist? Is there an integration between the specialist and the primary care? They need to look at it from the patient's standpoint,
Right,
as opposed from being sort of institutionally focused.
Yeah, that's a great point. And I think a lot of times you see the focus being more inward facing as opposed to outward facing. And then Dr. Bosco, is there any advice that you would give to some of the academic physician leaders? If we have a medical director, or say a department chair or a section chief listening that is thinking about expanding their service line, how do they create that right alignment to kind of change that focus? Maybe either in terms of balancing the different missions, or improving the financial performance of their section or department.
Well, that's a great idea. And the way we look at it is, a academic medical integrated musculoskeletal care delivery is a big tent, right? And so they have to rethink about how they look at their providers, their physicians and surgeons. You need to welcome a clinically competent physician or surgeon that may have no interest in teaching and has no interest in publishing, but they are contributing to the enterprise, as we say, by their clinical performance. They're providing excellent clinical care, and frankly, if they see a lot of patients, that those patients now can be research subjects of some of the researchers, right?
Right.
So they don't have to write papers. This idea that if you don't make tenure if you don't write 50 papers in 5 years, you're not going to make tenure, we're going to let you go. As long as they're contributing to the enterprise in a meaningful way and performing within the standard that we set, then they're welcome. They can actually choose not to work with the residents if they want. But that's the only way that you can expand. So you can have, I don't want to say different tiers, but many of your physicians have different ways they want to work. Some people want to work half time. Some people, want to work 80 hours a week.
Yeah.
it doesn't make any difference as long as they're
That's a great point,
contributing.
because I think if you can change that complement, and like you said, not having one physician that comes in with the pressures of being able to provide a certain level of research, maybe they just want to focus on that clinical support, then you build a strong complement of the faculty within that department. I think that's a great way of being able to ensure that the department is supporting their strategy as well as the strategy of the organization. Well, gentlemen, this was a great conversation. I really appreciate it. If any of our listeners want to contact you or maybe have some follow-up questions, Dr. Bosco, maybe we can start with you. Any information you can give on how they can possibly contact you?
Sure, they can email me is probably the best way at Joseph, JOSEPH.Bosco, BOSCO, at NYUMC, that's NYUMC like medical center.org.
Great. And how about you, Jeff?
Yeah, and feel free to email me, jpeters@luminahp.com.
Well, thank you, gentlemen. This is obviously a very important subject. I'd like to continue the conversation at some point down the road, certainly as we think about some specific initiatives as academics continue to align with their community-based partners. But until then, thank you again for joining me today, and a special thanks to our listeners for tuning in. Until the next insight, I am Daniel Marino, bringing you 30 minutes of value to your day. Take care.
Are you at a crossroad with value-based care? Do you need to chart a future strategy or improve your organizational performance? Visit us at luminahp.com to learn more about our consulting services and leadership development programs. Also, you can sign up for our newsletter on our website and follow us on Twitter and LinkedIn. For more information about value-based care insights, visit the programs page on healthcareradionow.com or luminahp.com. Join the conversation using our hashtag VBC Insights. We are Lumina Health Partners. Thank you for joining us today. Until the next value-based care insight, stay well.